Okay, so let's manage things. The commonest thing that you are going to ever have to manage urinary wise is a pesky UTI. So I've already put the management on there for you. For an uncomplicated UTI, it is quite simply a stat dose of ciprofloxacin, 500 milligrams. Also, the patient must be advised to drink a lot of water so they can flush out all of the bacteria. And you can also alkalinize the urine to help with the feeling of dysuria. So citrus soda is the commonest one. So that is very easy. That's very straightforward. I'm going to take this off now because the other two are slightly more complex and they're definitely more chronic and ongoing. Okay, before you even discuss any kind of intervention, you have to talk about lifestyle changes. Okay, so remember there was that other little cohort of stuff: fluid intake, caffeine intake, medication, especially diuretics, and things that can raise your intra-abdominal pressure, such as a chronic cough from smoking or poorly controlled asthma or whatever. These have to be managed. You have to have a discussion with your patient about these, because if you don't get on top of those, whatever intervention you're going to do is probably not going to help, or it certainly won't help as much as it should. So you need to get in control of that chronic cough. You need to make sure that there's not a lot of fluid being consumed at night. You need to decrease caffeine. That's both tea and coffee must come down. And if there are any diuretics that the patient is taking, then they must be taken in the morning. Okay, otherwise they can end up causing nocturia. So you got to deal with all this stuff first. Okay, that's quite clear. That's a prerequisite. Otherwise, the other stuff isn't going to help. Okay, actually, I'm going to move this down here so we've got our space there for management. All right. If we're going to manage detrusor instability, the least invasive means of managing detrusor instability is with a little bit of bladder training and modification. So you have to have dealt with all of this stuff. And then what you can do is, you have seen the terms bladder diary and bladder drills. I will put these, I'll scan these and put them up so you can actually see what they are. A bladder diary is something that's very useful for both the patient and the clinician. It shows you what the intake is, let me just get it so you can see it. Okay, so it just shows you what's been consumed. It shows you how often you've gone to the bathroom and how much is expelled when you urinate. It talks about accidental leaks. It talks about urgency. And it talks about what were you doing at the time that it happened. Okay, there's lots and lots of different kinds of bladder diaries. It probably really doesn't matter. This is just one that's quite visual. And as we all know, I like a visual thing. So a bladder diary helps actually define what the problem is and when it mostly occurs. And once you start getting that information, it will also help you monitor whether your intervention is working or not. Okay, so this is from Johns Hopkins. This is a little thing about bladder drills. So a bladder drill is basically retraining your detrusor to urinate when you want it to urinate. Okay, so the essence is that for the first 3 days, you're going to empty your bladder every hour. Then for the next 3 days, you try and knape for 1.5 hours before you void. Then the next 3 days, you try and knape for 2 hours. So you are gradually increasing the duration between urination so that it's not so incredibly disruptive. And your bladder is not just randomly contracting all the time. So it's quite literally, you are training your bladder to do what it needs to do. I'll scan this in so you can see, but I literally just Googled that so you can do the same. So those are the non-invasive things that can help to start teaching the bladder to urinate when the patient wants to urinate and not just when it feels like it. If that intervention fails by itself, then you step it up with your medical intervention. Your medical intervention in the first instance, those are tablets, okay, oxybutynin. Those are anticholinergics that can help stabilize the detrusor wall. They're very useful, but they've got a lot of side effects. Okay, now here's our, because remember, all overactive bladders normally happen in older women. So here's our old lady who's been prescribed oxybutynin, and nobody told her what the side effects were going to be. So whenever I ask students what are the side effects of anticholinergics, everyone says dry mouth and constipation, which is not untrue. That is entirely true, but those are not the ones that are going to lead to the death of the Sylvanian family. Okay, so remember that anticholinergics cause postural hypotension and they cause blurred vision. So here's your old lady now who starts taking her tablets and nobody's counseled her, and she gets postural hypotension when she gets up, and she falls over, and also she can't see, and she fractures her hip, and she ends up in hospital, and then death from pneumonia. Okay, so you have to be careful when you prescribe oxybutynin. I don't want to put you off prescribing it, but I want to make sure that you explain how to use it to your patient, and you start at a low dose. A low dose is 5 milligrams once a day. You can build it up to BD and you can increase the dose from there. But you have to tell your patient that they need to take it at night, and they need to be sure that they're sitting down or they're not going to go anywhere, because you need to warn them about the dizziness and the blurred vision, okay, so that they don't fall over. All right. If your oxybutynin doesn't help, or it has intolerable side effects, which is entirely possible, the next step, where available, would be to inject the detrusor with Botox. That just calms the whole thing down. It prevents it from contracting randomly whenever it wants. It's only available in tertiary care. It's probably not available across the country, but it is quite a nice option for overactive bladder. So those are essentially it for the interventions. There are a couple of other things, but I don't think you really need to know them at your level. So we're now going to move on to your pelvic floor. So when we're talking about pelvic floor dysfunction, what do we actually mean? Well, here's a nice little illustration. If your pelvic floor starts collapsing, your bladder starts falling down, right? And what that does is that it shortens the urethra, and it makes it much easier for urine to escape. So your aim when you are dealing with a pelvic floor dysfunction, which is manifesting as stress incontinence, which is as a result either of bladder prolapse or uterovaginal prolapse, you have to strengthen this and try and get it back to its former glory. You're going to manage all this stuff also, because it all matters and it all counts. Okay. How are you going to deal with your, let me just reach across here and get my little notes for you. Okay, so how are you going to deal with stress incontinence as a result of prolapse? Well, if you have got grade 1 to 2, so it's still above the introitus, then Kegels, a pessary, if you have access to that in primary care, I don't know, and you probably don't have the skills to determine what size. You could also give Premarin cream if somebody is postmenopausal, because it plumps up that tissue and it just kind of helps the whole system get strong again. So here's your Kegels. Okay, I'll put this on a separate picture as well. The essence, you can do them sitting or lying down with bridging. That exercise is called bridging, that you can see there. The essence is that you have to use the muscles that stop urinary flow. The aim is not to stop urinary flow. I've had patients who stopped doing the exercises when their bladder was empty because they misunderstood me. That's just to teach them what the feeling is and what the right exercise is. And you have to build it up. So you start holding for 3 seconds, and every week you build up by another second until you're holding for 10 seconds. You want to end up doing it 3 times a day. That needs to be done like that properly for about 3 months to see any, like, the maximal effect that it's going to have. So it requires a lot of patient motivation. pessary for grades 1 or 2 is always an excellent intervention, life-changing, in fact. But you're probably not going to have access to that. So if you have a patient with stress incontinence and prolapse and Kegels are not working, you might need to refer for a pessary or further intervention. And this used to be Rooibos night cream, but this is now Premarin cream. If you're going to ever put a pessary in, you must also give Premarin cream to help keep the mucosa around there moist. You can do that just with the Kegels exercises as well, just to help plump up all of that tissue. If you are dealing with a grade 3 to 4 prolapse, so that's beyond the introitus, it's highly unlikely that your Kegels or your pessary are going to be able to manage that because things are so far gone. So ultimately, if you see someone with a grade 3 or 4 prolapse, you need to refer them for assessment for surgery. What surgery? I don't know. I don't expect you to know. It's not important for you. But it is important to understand that by the time you are here, grade 3 or 4, just the force of everything that is coming down is going to make it very difficult for just a pessary or the Kegels to get things back up to where they were. So you are probably going to have to refer for a surgical opinion. Okay, so those are the things that you can manage at primary care. Another thing to note is that if you have mixed incontinence, so you have got urgency and frequency and you've got stress incontinence as well, so it's a whole combination of this story, those patients need to be referred because they often need like multiple things to happen. But you can certainly try and manage the individual symptoms the way we have discussed, but you probably need to refer them. They're going to need to have urodynamic studies if possible. Okay, so that is Urogyne for idiots. It's just a few things to kind of give you a visual to hang stuff that's in the chapter onto, and hopefully make it easier for you to navigate what is important for you to really understand and what you need to know about so that you can refer. That's it. Peace out.